Pulpectomy. Primary teeth are an important element of dentition. They should be saved because the sequel of the early loss of primary teeth can lead to various circumstances, such as there can be mesial tipping of the molars if there is early loss of the first molar. Then there can be insufficient space in the arch for further eruption of other permanent teeth, which may lead to blockage of either the premolars or other teeth to erupt. Even there can be a transposition or ectopic eruption of the successor permanent teeth. There can be also a midline shift. It can also lead to aberrant oral habits like tongue thirsting, because the tongue has the tendency to force itself in the gaps of the oral cavity. So, it can also lead to extrusion of the opposing teeth. For example, if mandibular first primary molar is lost, it can lead to the eruption or the over extrusion of the maxillary first primary molar, which can also block further permanent teeth to erupt in the oral cavity. Now, we will go on to various treatment modalities of primary teeth, that is the pulp therapies. Today, we will be discussing about pulpectomy. Now, what basically is pulpectomy? Pulpectomy involves the removal of the coronal portion of the pulp as well as the radicular portion of the pulp. It is preceded by removal of the roof of the pulpal cavity, followed by the contents of the pulpal cavity in order to gain access to the radicular portion of the tooth, which is debrided and further filled by a suitable obturating material. So, pulpectomy can be defined as the removal of necrotic pulp tissue and filling it by a resorbable cement or a material. But more often the term partial pulpectomy is used, or the pulp canal treatment is used for the purpose of pulpectomy. This is because the non-negotiable canals which are present in deciduous roots, the aberrant anatomy of the canals of deciduous molars, the irregularity of the canals. Moreover, there are so many number of accessory canals in the primary pulp, that is, they are unable to get obturated. There is also difficulty in determining the apex. This is because of the ever going on resorption in the primary roots. So, let us progress further to what are the objectives of pulpectomy. The prime objective is to maintain the tooth in the arch or to preserve the tooth so as to prevent the sequel of the early loss of primary tooth. Furthermore, the objective is to biomechanically cleanse and obturate the canal. The term biomechanical is used, or biochemical is used for pulpectomy, because both the irrigating solutions and the mechanical file motion is used for cleaning the pulp canals. Furthermore, it also has the objective to hold the primary tooth in the oral cavity in a non-pathological state, and moreover to promote the physiological resorption of root. That is, if we fill the pulp canal with the obturating material, the rate of resorption of the obturating material should be same as the rate of resorption of the root of the primary tooth, so as they can exfoliate at the normal time and facilitate the eruption of the permanent tooth or the permanent successor. The main rationale behind the pulpectomy treatment is to gain access to the radicular pulp, then to remove the radicular pulp which is infected, And finally, to fill the root canals with a suitable resorbable material, which should also be biocompatible. Now, there are various considerations for the purpose of pulpectomy, which are the number of the canals which are present in the root, the chronology of the tooth, even the psychological and cosmetic factors of the patient, that it should be aesthetically acceptable and pleasing, the number of tooth which need to be pulpectomized, the anatomy of the roots. For example, we generally find ribbon-shaped canals of deciduous molars, and even it is also dependent on the number of accessory canals present and the proximity or the nearness of the permanent successor from the primary tooth. Now, there are various case selection criteria for the process of pulpectomy. That what are the indications in the tooth in which pulpectomy could be done? They are either divided into general indications, general contraindications, then clinical indications and clinical contraindications, and also the radiographic indications and the radiographic contraindications. Now, under the general indications, we can say if the patient is healthy and cooperative without undergoing any medical disorder, the patient is said to be healthy to be pulpectomized. Then, if the patient is suffering from any blood disorder or if the patient is having a congenital heart disease, generally we do not consider that person healthy to get pulpectomized for a teeth. In highly uncooperative patients who will not cooperate or open their mouth in the dental clinic, in such patients also pulpectomy is contraindicated and we generally perform procedures under general anesthesia. Then coming over to the clinical indications. If the patient reports the history of spontaneous pain or pain on chewing or mastication, he may also report pain on having hot and cold fluids or foods and nocturnal pain. Such a tooth can be indicated for pulpectomy, but the final diagnosis should only be done after radiographic investigation. Even the primary tooth with inflammation which is extending to the radicular pulp will go for pulpectomy with a necrotic pulp but minimal to root resorption, that is, ideally more than 3/4 of the root should be present for the purpose of pulpectomy. Then, sometimes there can also be a presence of a sinus tract or a fistula or a soma in the gingival portion of the tooth. This will indicate an abscess or the periapical abscess in the tooth. In the case of pulpless primary tooth with absent permanent successors, for example, if we take OPG of a patient and we find that the permanent successors for that particular tooth are absent, then it is mandatory to do pulpectomy for that particular primary tooth. Even in the case of anterior teeth, if aesthetics, mastication and the confidence of patient is considered, they should be pulpectomized if they are pulpally infected. Because anterior teeth do not play a major role in space loss. They can be kept for the purpose of aesthetic functionality and mastication. Even the primary tooth which are next to the palatal cleft, and if they are pulpally infected, they should be obturated and pulpectomized. The pulpectomy can also be done in those teeth which are holding orthodontic appliance or which need to be kept for the purpose of space maintenance. Then the radiographic and the clinical contraindications can be if there is mobility in the tooth, if there is more than 3/4 of the resorption of the tooth root, then in that particular tooth we do not indicate pulpectomy, but extraction is generally done in such patients. If the tooth is highly restorable, that is, maximum part of the tooth structure is lost, we do not consider that tooth for restorative purpose. If the communication is present between the floor of the pulpal chamber and the furcation area, that is, there is through and through communication. Moreover, if the communication exists between the gingival portion of the tooth and the pulpal chamber, that is, tooth which is contraindicated for pulpectomy. On radiographic investigation, if more than 3/4 of the root is present, that tooth is indicated for pulpectomy. If suppose there is a periapical abscess, then also pulpectomy can be indicated. But if the tooth is having any abscess, cyst, then or a dentigerous cyst, a radicular cyst, internal or external resorption, and if there is no interradicular bony support is present, in such tooth we will not go for pulpectomy, rather we would go for extraction. Now, pulpectomy can be classified into either a single visit pulpectomy or a multiple visit pulpectomy, wherein we perform the pulpectomy procedure in various visits. So, this is depending upon the number of visits of the patient by which pulpectomy can be classified. Then on the basis of the amount of pulpal tissue removed, pulpectomy can be classified either into partial or total pulpectomy. In partial pulpectomy, we just remove the part of the pulpal tissue that is infected by the means of H files. So coming over in a descriptive form to single visit and multiple visit pulpectomy. Starting with the single visit pulpectomy. So generally this type of pulpectomy is carried over as an extension to the procedure of pulpotomy. If suppose we have decided to do pulpotomy on the tooth, but on opening the pulp chamber, a dentist is not able to cessate the hemorrhage which is present. So on the spot decision for this is made. If hemorrhage from the amputated pulpal stump is uncontrollable, in such cases we go for single visit pulpectomy. If we see that there is no periapical change observed or no periapical radiolucency, in such cases we will go for single visit pulpectomy, wherein the same visit the entire pulpal cavity is evacuated along with the radicular pulp, cleaned, shaped, irrigated, and finally obturated by a resorbable obturating material. The major indications for this type of pulpectomy is if there is a large carious lesion and in the primary tooth, if the infection is extending beyond the coronal pulp to the radicular pulp. Moreover, if the hemorrhage from the amputated pulpal stumps is dark red in color and slowly oozing out, but which is uncontrollable by any medicaments. So, coming over in detail to the step-by-step procedure of pulpectomy, that is the single visit pulpectomy. First of all, the mandatory step is to anesthetize the tooth for the purpose of comfort of both the patient as well as the operator. But if in some cases, if the pulpal tissue or the tooth is entirely non-vital, then it is not necessary to anesthetize the patient because the patient will not feel any pain at all in a non-vital tooth. But if we inject the patient with local anesthesia, the patient may get apprehensive. So, wherever necessary, local anesthesia should be given. Then, later on, the tooth should be isolated with a rubber dam. After isolating the tooth with a rubber dam and application of a rubber dam, excess cavity is started by the means of round burrs and all the carious process is removed to obtain a clean operative field. Thereafter, all the accessible coronal pulp is removed. The axis should always be straight line for the purpose of clear visibility and accessibility of instruments. And finally, after gaining of proper access and evacuation of the coronal pulp chamber, the radicular pulp is reached. The number of canals are identified, the canal orifices are identified, and the barb brooches are inserted inside the orifices so that to reach the pulpal canals. And a working length IOPA is taken and the working length is established. By the means of barb brooches, we extirpate the pulpal stump's pulp and further irrigate it with a saline solution. We can also use additively EDTA or sodium hypochlorite for the purpose of obtaining a chemomechanical debridement. So, finally, a diagnostic radiograph of working length is taken and the working length is established. After taking of the working length, the biomechanical preparation for the canal is done by progressive using of files. Then after, the canals should be dried with paper points, and if the canal is dry, finally the canals are filled with the aim of enlarging the canals by the biomechanical preparation. Furthermore, condensed by obturating material which is bioresorbable. The final restoration is placed by GIC or reinforced zinc polycarboxylate cement and stainless steel crown is incorporated in the tooth. Now, in the single visit pulpectomy, care should be taken that circumferential filing of the canals is done. That is, the file should be used in a to and fro motion, in and out motion, so that even the dentinal shavings and the canals are cleaned properly. The dentinal shavings can be flushed out from the canals by the means of irrigating solution. And finally, after the entire pulpal cavity is evacuated and the final walls are confluent with that of the canals, the obturation is done. Now progressing further to multiple visit pulpectomy. Now what are the indications of the same? If suppose there is a periapical abscess which is associated with the root of the primary molar or the tooth which needs to be pulpectomized. If there is a presence of a sinus tract in the sulcus area which is opposite to the tooth. If the pulp is completely necrotic with the periapical involvement. In such cases, we go for multiple visit pulpectomy. Now what is the procedure for the same? First and the foremost step is to give local anesthesia and rubber dam application. Then all the caries which is present over the coronal portion of the tooth is removed and the access is obtained, which is obtained with a high speed round burr number 7 or number 8. Then the pulpal chamber is identified and opened. We should be careful while opening the pulpal chamber as not to touch the floor of the pulpal cavity, and this portion should be done in a slow motion. Any pressure which is present in the pulpal chamber due to pus accumulation will be released at this stage and the patient will get relief from pain or any acute symptoms. But it is very important to maintain a straight line access to the pulpal chamber. This is because in order to obtain proper visibility, proper accessibility for the root canal instruments, and in order to maintain proper obturation and even conservation of the size of the tooth, that is to avoid any excess cutting of the tooth structure. The unroofing of the pulpal chamber should be done in the proper way and further after to remove the pulpal horns. So the main need to obtain a straight line axis is to determine the working length properly for the purpose of proper debridement and proper irrigation, proper biomechanical preparation, which will be followed by a perfect obturation. So, a low speed burr further is used to evacuate the entire coronal pulp. It can also be substituted by the means of a sharp spoon-shaped excavator. We can use it in scooping motion throughout the pulpal chamber to evacuate all the contents. Now after the evacuation of the pulpal chamber contents, we go for working length determination. Now what is the importance of this step? If we do not take a working length pre-operative IOPA, then it can lead to incomplete instrumation or ledge formation in between the canals, which will hinder with further obturation. Even if more filing is done, it can lead to apical perforation or underfilling or overfilling if there is an error in determining the working length. So, an important or even the mandatory step for pulpectomy is determination of working length, which can be done either by radiographic methods or non-radiographic methods. The radiographic methods constitute conventional method, that is Grossman or Engel method, then by the means of RVG or radiovisiography or zero radiography. Even digital radiography is a radiographic method of working length determination. This can be done both in primary and permanent tooth. The non-radiographic methods, they constitute tactile response. For example, if we insert a file and the patient is having pain, or if there's an apical stoppage, by the means of files we can determine that. The working length can be established to the same. Another methods are paper point method or by the means of apex locator, which can be either electrical or mechanical type. So finally, after the determination of working length, we can go for biomechanical preparation. Now, exactly working length is a distance between the coronal reference point of the tooth. For example, in molars, we take cusp tips or marginal ridges as reference points, and we adjust the stoppers of the instrument to that level, and from that portion to the apical portion, generally 2 to 3 millimeter less is measured. So a diagnostic radiograph can be taken with the files. Now leading further to biomechanical preparation. First, with the endodontic file, we locate the canals and all the pulpal tissue is extirpated by the means of fine barbed broach. After the tissue extirpation is done, we go for circumferential filing by progressing from 8, 10, 15, 20, 25, 30 and furthermore. After doing reciprocal filing, finally the dentinal shavings are irrigated out from the canal by alternative use of either saline and sodium hypochlorite. H files can also be used in between to have a funnel-like shape of the canals, so the obturating material can easily flow into the canals and a three-dimensional seal can be obtained. After drying the canals properly by the means of paper points, and if we see there is no residual liquids or fluids present in the canal, no residual pulp or dentinal shavings present in the canal, we can progress to obturating of the canal. Now, obturation is obtained that is a three-dimensional seal which will seal the canals or the tooth from either periapical leakage or any infection from the periapical region to travel to the tooth. Even it offends the region of the coronal portion too. That is, any infection from the coronal portion cannot reach the canals by the means of proper obturating material. Now, the aims of obturation are to prevent any recontamination to the root canal, as I have already explained. Once the patient is free from any clinical signs and symptoms, the canal is dried and the canal is filled with a reabsorbable paste. But GP points, that is gutta percha points or silver points, are contraindicated for use in primary tooth because these are non-resorbable. They can only be used in permanent molars or other permanent teeth. The ideal requisites or the requirements for any obturating material is that first of all, it should be biocompatible to the tooth structure. It should not cause any harm to the tooth or the surrounding tissues. Then it should be antibacterial, that is, if any remaining infection is there, it should stop the infection at that point of time. And furthermore, it should also be easily inserted into the canal or can be easily retrieved or removed from the canal. It should adhere to the walls and stick onto the walls of the pulpal canal. For example, not to avoid any voids, not to prepare for any voids in the canal. It should also not discolor the tooth structure. Now there are various obturation techniques which are used in primary teeth. They can be either by the means of pressure syringes, which was discovered by Dr. Greenberg. So basically, these pressure syringes, they are an apparatus which consist of a syringe, a barrel and a wrench. The syringe, the barrel and the wrench, the needle of the syringe is inserted into the canals and the wrench is drawn. The needle is slowly withdrawn from the canal 3 mm by 3 mm and the obturating material is deposited into the canal by the means of rotating the wrench of the needle. This was a Greenberg needle or pressure syringe which was advocated by Dr. Greenberg. Further, other types of needles are mechanical needle, which has 30 gauge needle, which is again inserted into the canals for the purpose of deposition of the biocompatible material, obturating material into the root canal. There is also tuberculin syringe, which is used for obturation. It is a 26 gauge needle which is 3 by 8 inch in length, which can be inserted into the canals for obtaining obturation. Obturation can also be obtained by incremental filling method by the means of pluggers. Here, the obturating material can be shaped in the form of flame and further tapped into the canals by the means of pluggers. Lenturous spirals, which were discovered by Dr. Koppel, are one of the most accepted techniques presently. Here, the spirals are inserted or they are rotated over the obturating material, thick paste, which are further inserted into the canal cavity and are drawn. Then excess material is deposited into the canal. The lenturous spirals can either be hand-held or can be used with a slow speed handpiece. This will also avoid overtime and can be used for a very short period of time. Now, how can obturation be assessed? They can be assessed by the means of post-operative radiographs. There should be no voids present in the obturating material in the canals. They should be of radio opaque in nature and the filling should neither be underfilling or overfilling. That is, the material should ideally not extrude out of the canal. Finally, the pulp chamber is filled with a cement like zinc polycarboxylate or glass enamel cement and restored by a stainless steel crown for the purpose of maintaining the aesthetics and the mastication. Now there are certain materials which are used for obturation. They are zinc oxide eugenol, calcium hydroxide paste, Iodoform, Vitapex, Metapex, MTA, Endoflas, Moistose paste and Volkov's paste. We'll be discussing about a few in the further slides. So, one of the most primitive material was zinc oxide eugenol. It is one of the materials which has biocompatible properties and it is highly bactericidal. It will cessate any infection in the canal. It's radiopaque in nature, so it can be easily identified in radiographs and is resorbable too. But the main disadvantage of the zinc oxide eugenol is the rate of resorption is not equivalent to that of rate of resorption of the root. That is, if the root is resorbing, the paste which is present in the canal will not resorb equivalently. So, there are chances of retaining of that primary tooth which is obturated. That is, the resorption of zinc oxide eugenol in the canals is very slow. Generally, we have to extract the teeth when the permanent teeth is about to erupt. There can also be foreign body reactions if zinc oxide eugenol is extruded periapically, that it is lesser biocompatible than any other materials. So overfilling is not preferred in such cases. They can also be deflection of permanent tooth if the tooth is filled by zinc oxide eugenol paste. But the advantages are that they adhere to the wall properly, so avoiding any voids in the canal cavity or providing a three-dimensional seal. They do not discolor the tooth, are radiopaque and can easily be applied. They are also having antiseptic and antibacterial properties. But zinc oxide eugenol paste sets into a hard mask. So, if removal is preferred, it cannot be easily removed from the canal. Now, coming over to Vitapex or Metapex. It consists of Iodoform, calcium hydroxide and silicon, which was discovered in Japan and USA and used further and has good clinical and radiographic results which are in the studies which were carried out. The main advantage of Metapex or Vitapex is if it is extruded out from the periapical cavity, it will resolve within 2 weeks. It is easily delivered. It is delivered in the form of syringe and we can insert the nozzle of the syringe easily into the canals and adjust the stopper and deposit the obturating material in the primary root canals. A success history of this is present for both Metapex and Vitapex, and many successful cases have been reported over years for the particular medicaments. They have also proven beneficial effects over Iodoform paste. Coming over to Moistose paste, it is a sterile Iodoform parachlorophenol camphorated methylated compound. It's also named as Volkov's paste. It constitutes zinc oxide, Iodoform, thymol and linolol. It is another preferred material for obturation in primary root canals. The KRI paste or the Iodoform paste. It is composed of Iodoform, camphor, parachlorophenol and menthol. There are various advantages for this paste, that it has a rapid resorption, or the rate of resorption or the absorption of this paste is same as that of the root canals. So the tooth will be exfoliated at its normal original time. There are also no side effects on the successor tooth. If the paste is extruded out through the periapical region, it will resorb easily. Further also, it does not dissolve with the help of oral fluids, and if it is extruded out from the periapical region, it can be easily replaced by the normal tissue. It is also easily removed out from the canal and do not set into the hard mass. The delivery system of Iodoform paste is easy by the means of syringe, and generally 84% success is reported of the cases which are obturated by Iodoform paste. Endoflas has been reported to have low success rates than that of Iodoform, Metapex or Vitopex, but it is a resorbable paste, which is another preferable material for obturating primary root canals. It is composed of barium sulfate, which is a radiopaque agent, calcium hydroxide, which is antibacterial, iodoform, which can act as a preservative, and zinc oxide eugenol, which is also antibacterial in nature. The Vitopex and the Metapex are one of the most preferable obturating materials for primary teeth because they have highly potent antibacterial nature. They can be easily resorbed if they are extruded out from the periapical region in the period of 2 to 4 weeks and be restored by the normal tissue. They can also be easily applied and retrieved from the canal if required. The rate of resorption is same of that of the root, so the tooth will be exfoliated at normal time. Furthermore, there is also no adverse effect on the successor tooth if primary teeth are filled by Metapex or Vitopex. They have a long-lasting bactericidal property also. They have oily adhesives which can adhere to the walls of the primary root canal and provide a three-dimensional hermetic seal. So, coming over to the recent methods of pulpectomy, that is laser pulpectomy. In laser pulpectomy, it uses a hydrokinetic energy which is produced in combination with highly small atomized water with the laser energy. So, the canals can be easily cleaned by the process and further obturated. The advantages of laser pulpectomy is that it provides a superior patient and the operator comfort. There is no use of local anesthesia or pain to the patient. There are reduced post-operative complications or blood loss. It is a versatile and effective method, and the vibrations or the mechanical force which is used is minimal. Moreover, maximum tooth structure is preserved or conserved in the case of laser pulpectomy. So, collagen or collagen is another material which can be used for the pulpectomy procedure and obturation. It is a soft, white, pliable material which is made up of bovine collagen. Then, pulpectomy in the tooth. After obturation, the teeth will require follow-up visits. We will advise the patient to visit the clinic every 3 to 6 months for follow-up examination, and the monitoring should be done further. I have already told, if the crown is obturated with zinc oxide eugenol paste, since the rate of resorption is slow, we need to extract the primary tooth if the permanent successor is about to erupt. If there is a case of acute alveolar abscess in primary tooth, then immediate access cavity should be prepared to release any pressure from the pulpal contents and the pus in the pulpal chamber so that the patient is relieved of pain, and in the further visits, cleaning and obturation can be done if the pulpal canals are dry. So, pulpectomy is a mandatory step or a mandatory procedure to hold the primary tooth in the oral cavity in a non-pathological state, so as to prevent any loss of space in the arch and any complications from extraction of the primary teeth. Thank you.